बहुत कॉमन क्वेश्चन है आजकल, व्हाट इज कैंसर?
इट्स लाइक एनी अदर डिजीज। सो आप अगर बॉडी को ऐसे ऐसे देखोगे, सेल्स को देखोगे, तो सेल ग्रो करते हैं नेचुरली, वी ऑल नो सेल ग्रो करते हैं। अब उनकी ग्रोथ के लिए बॉडी ने बड़ा स्मार्टली, बॉडी बोले भगवान बोले, बड़ा स्मार्टली कुछ चेक्स लगाए हुए हैं कि भाई एक सर्टेन लिमिट के बियॉन्ड ना तो साइज बड़ा होगा ना नंबर्स बड़े होंगे
जी।
अब ये चेक्स जो है डिटरमाइन करता है आपका योर जेनेटिक एंड योर बेसिकली डीएनए जो है, दैट विल डिटरमाइन कि दिस चेक्स विल बी देयर।
ओके।
So now when one of these checks go away, so there is an uncontrolled growth. So that uncontrolled growth takes the form of a tumor, and that is what it is, cancer.
Hi, I'm Vishal Laroia. I welcome you to a special program where we're discussing about oncology as a subject, where we are specialized in oncosurgery. So we have a doctor here with us who's been 21 years plus experience in terms of oncosurgery division. So we welcome Dr. Piyush Kumar Aggarwal, who is a specialist, and we would like to discuss a lot about an opportunity in terms of the treatments available for oncology, as well as the latest trends and his experience in terms of the onco division.
Thank you. I'm Dr. Piyush Kumar Aggarwal, Director of Surgical Oncology. So Vishal, thank you for inviting me to this podcast. I hope through this podcast we will be able to deliver some awareness into the common folks, and we will be able to make a difference into their lives, in the lives of people who are already suffering from cancer, or in the lives of people who are not, but we create awareness so that effectively anybody who is developing cancer or is supposed to develop cancer will land up at the hospital in the early stage, so that we are able to cure the disease.
First of all, आपसे एक क्वेश्चन है जो कि बहुत कॉमन क्वेश्चन है आजकल, व्हाट इज कैंसर? एक ऐसा वर्ड जिसको देख के नाम सुनते ही सब में घबराहट आ जाती है, ये लगता है एंड ऑफ लाइफ, एंड ऑफ एवरीथिंग। तो उसमें आपका पर्सपेक्टिव क्या है?
See, it's like any other disease. So आप अगर बॉडी को ऐसे ऐसे देखोगे, सेल्स को देखोगे, तो सेल ग्रो करते हैं नेचुरली, वी ऑल नो सेल ग्रो करते हैं। अब उनकी ग्रोथ के लिए बॉडी ने बड़ा स्मार्टली, बॉडी बोले भगवान बोले, बड़ा स्मार्टली कुछ चेक्स लगाए हुए हैं कि भाई एक सर्टेन लिमिट के बियॉन्ड ना तो साइज बड़ा होगा ना नंबर्स बड़े होंगे
जी।
अब ये चेक्स जो है डिटरमाइन करता है आपका योर जेनेटिक एंड योर बेसिकली डीएनए जो है, दैट विल डिटरमाइन कि दिस चेक्स विल बी देयर।
ओके।
So now when one of these checks go away, so there is an uncontrolled growth. So that uncontrolled growth takes the form of a tumor, and that is what it is, cancer. Now you will see sometimes there are ulcers, not tumors. So now it never starts as an ulcer, it starts as a tumor. When it outgrows the supply, now so there is a blood supply to the tumor. So anything that needs to survive in our body needs blood supply. So when it outgrows, the size outgrows the blood supply that is available, it ruptures, the surface ruptures, it gets necrosed, and that it takes the form of an ulcer.
If you talk about a few years back, when the word cancer comes in the name, where the patient knows that you have a cancer, we see in a lot of Indian movies, you know, the blood cancers or any tumors and everything. It seems like it's just end of the patient, you have few days to live. But now, with the technology, with the experience, we have seen that there's a tremendous outcome in terms of the patient treatment. So what kind of treatment do you give it to your patients? And in terms of technology, how we have gone past in the last few years, how we have improved?
So I am basically a surgical oncologist. So I operate on cancers.
Okay.
So I operate from head to toe. So I'm trained at Ahmedabad. It's a renowned institute called Gujarat Cancer Institute. So now when we talk about cancer, so I have been very fortunate to be associated with cancer surgery from very long time. So when I joined my PG 2004, I joined under my guy, Dr. Kapoor, who was basically a fellow from Tata. So from the first day of PG, so it has been almost 21 years, I am seeing cancer. Now, cancer, yes, definitely. There was a time when we all used to think cancer means done and over with. Now we slowly have realized cancer is just like any other disease. Right. So be it diabetes, be it hypertension, be it dengue. So if you come to the hospital at the right time, so even if you take diabetes, if you come to hospital in a very, very advanced stage, in a very, very uncontrolled way, chances of survival are less.
True.
So same is with cancer. If you diagnose it early, you come to hospital early. If I am able to diagnose it early, the chances of cure are very, very high, like any other disease. So now, because of the development, a lot of development have taken place. Now, not only just the development in terms of cure, the development has been in terms of understanding cancer, how it behaves. Now, you can just take cancer like any one other body inside your body,
Yes.
which is growing, and it has its own mind.
Okay.
So it will not listen to you. It will not listen to anybody. And it has its own character, own way. Every single cancer, if you take head neck cancer, they have a different way of presentation. If you take breast cancer, it has a different way. If we talk about hepatopancreatic biliary, it has a different way. Now, as our understanding of cancers is growing, so our understanding of dealing with them is also growing. So I'll just give you an example. So at one point of time, ovarian cancers, if we open up and if we find nodules in the abdomen, we will consider it to be inoperable. True. And the patient will be given 3 to 6 months. Now with advancement of technology and the better understanding of organs, we realize that it is a localized disease. We don't call it now metastatic disease.
Okay.
We don't call it for us it is not stage 4, it is still a treatable cancer. So what we do is, we send the patient to medical oncologist, give chemotherapy, reduce the burden of disease, then operate. And because we realize it's a localized disease inside the abdomen, so giving chemotherapy there will help. So when they were experimenting with it, they realized heating the chemotherapy does wonders.
Okay.
So now that procedure right now is called HIPEC.
Okay.
So now the use has increased to colonic cancers, the use has increased to stomach cancers, the use has increased to appendicular cancers. Now anything that is localized in the abdomen, now we are realized that can be treated. So same thing when we used to see buccal mucosa, oral cavity cancers, it was a lot of morbidity because there was no reconstruction. You will cut the mandible off, patient is living without mandible. So imagine the kind of morbidity you are carrying. Your half mandible is there. It will go like this.
Right.
Patient cannot eat. Now what has happened is, with advancement in microvascular surgery, now we are using bone from leg or soft tissue from leg or soft tissue from hand to reconstruct everything. Now if you see a tongue cancer patient with the reconstruction, you cannot even tell that he has been operated. And furthermore advancement, we started doing one thing in head neck cancer. No, earlier what happened was, head neck cancer, there will be a lot of mutilation.
Okay.
So the incision will go like this, there will be vertical incision or this. So once you see the patient from outside, from a kilometer away, you can realize, okay, this patient has been operated. Now what we are doing is, we are going from neck.
Right.
Small incisions in the neck, we go from neck, we operate there, from there. Now if you see my patients from a distance, you cannot even tell the patient has been operated. Same with breast cancer. If we talk about breast cancer, now breast cancer, the survival we are counting in 20 years. So normally cancer survival is counted in 5 years survival. Now breast cancer, we are talking about 20 years survival. Even in the worst outcome, patients are surviving even the metastatic disease.
Right.
Another thing that came up was removal of metastasis.
Okay.
Now earlier what used to happen, you have one metastasis in the lung, you are done and over with. Now we treat it. So we first try to treat it with chemotherapy. If it doesn't help, then if it is operable, we operate also. Although there are certain guidelines for it, but still at one point of time, I realized 20 years ago, we were not even able to deal with it. Now we are thinking about curing. And I know so many patients of mine who had metastatic disease, who are now cured, living happy.
Next thing we wanted to check with you is that you're seeing that from open surgery to laparoscopic surgery now. There are a lot of places where we don't do a laparoscopic surgery, still an open surgery is to be done. Are most of the cancer treatments have been done through laparoscopic, or it's a mix of both?
So let me give you a broad idea into how laparoscopy and robotics work. So the basic concept of laparoscopy and robotic was to avoid big incisions. Now what happens is when you open up an abdomen or a thorax, so let's talk about thorax. One of the most difficult side that used to be earlier was thorax. Now if you are going to open up the thorax like this, what happens in post-operative period is there is a lot of pain. Patient will not breathe. Now if they won't breathe, the lung won't expand.
Right.
Lung won't expand, eventually patient will have pneumonia. The chances of mortality were very high. Now what has happened is they reduced the incision size. They realized you don't have to give those. So it came with the scopes.
Small incision.
They started giving a small incision called video assisted thoracoscopic surgery. Now we give a small incision, put scopes inside, and then operate. Now the further advancement took place. So when you talk about food pipe cancer, the further advancement or we will put the patient into prone position. Okay. And then we put 3 scopes and we mobilize the esophagus through those 3 scopes. So there is no scar on the chest, there is no incision. The post-operative outcomes were remarkably very different.
Okay.
So now the same thing happened with abdomen. See, laparoscopy works very well into the areas where there are cavities.
Right.
So it has to be an empty cavity. It works wonderfully well. So we talk about chest, we talk about abdomen. These are empty cavities. So same abdomen. So now if you have to open, you go by midline incision. So it's a big incision. Chances of hernia are very high. There are adhesions post-operative. Patient suffers a lot.
Right.
So now with advent of laparoscopy and robotic, you'll put 3 or 4 port. You have small incisions, 1 centimeter size incisions.
Correct.
And then when you have to deliver the specimen, so you can give a small incision, which is a transverse incision. Chances of morbidity are less. Chances of hernia are very, very less. And post-operative pain is very, very limited. Also at the same time, it's not just about the patient only. So laparoscopy and robotic gives me a vision, very good vision. So with naked eye, I can see to a limit. It's not 2x or 3x vision. So when I put my scope inside, my camera is going to give me 2x, 3x vision. It will be 4K kind of vision. So I can see structures much better compared to the naked eye.
Right.
Plus then there are areas like pelvis, these subdiaphragmatic areas. Now they were very, very difficult to reach through naked eye because the vision is like this tunnel vision. Now with laparoscope, I can go till deep in the pelvis, deep in the. So my dissection becomes easier. Though learning curve definitely is there, you have to learn it under somebody.
Right.
But once you learn it, the learning curve is much less. The learning curve once it basically goes down, the level of dissection, the chances of morbidity, the chances of injuring something becomes very less. And it became much better with robotics.
Right.
Now the robot is like I'm sitting in the corner, like you are sitting here, there is a console, I'm sitting here, patient is here, my robotic arm goes inside the patient, I control from there. Now advantage of robot is, see their arms have flexibility.
Right.
I cannot do multi-directional flexibility. My robot arm can go anywhere. I can operate from below.
Right.
So now when I have to operate from up, not below.
Right.
So robot can go from below. So it has remarkably increased the use of basically instrument in a way we never knew they can be used.
So in a way, the laparoscopic or robotic surgery is good for patient as well as for the doctors. So the good outcome we come to know. Now, taking it further, when we say laparoscopic or robotic surgeries, now we have seen in your some of your surgeries which you have done in past, you have taken out big tumors. But when you say 2 mm of insertions, how do you take out such a big tumors from that small holes?
So whenever you see, if somebody has written properly, you will never see laparoscopic surgery. They will write laparoscopic assisted, robotic assisted.
Okay.
So now what is the meaning of assisted? So the meaning of assisted is I will mobilize the whole tumor through laparoscopy.
Okay.
So if I have to take out the colon, it has to see, it will be this big specimen.
Right.
You cannot take it out without incision. You have to give an incision.
Right.
So we are not avoiding complete incision. We are avoiding the big incisions. We are limiting the size of incisions and we are deciding where to give it. Now what happens is laparoscopically, I will mobilize the whole thing. Be it kidney, be it intestine, I will mobilize, I will ligate the pedicles, whatever artery and vein are going, I will ligate, I will separate it.
Correct.
Then I will take it out, throw an incision in the abdomen. which will be very small, first. Second, it will be more suitable incision.
Right.
It will not be kind of incision which has chances of giving away, chances of converting it into hernia.
Mhm.
It will be an incision which is much safer for the patient and cosmetically better.
Okay.
So it's always laparoscopic assisted and robotic assisted.
So you've been treating a lot of patients from domestically within India as well as patients from abroad. So any two examples you wanted to give, which were very complicated cases, and the eventual results came out really well.
So effectively, I have ample number of examples. I'll give you in brief few examples. One patient came to us from Iraq. He had a nasopharyngeal carcinoma treated 10 years ago, and then he had a recurrence in the parotid. Parotid, there are nodes, there was recurrence. So he was deemed operable. He was given few months of time. Everybody said, because if it is metastasis, we should not be doing anything. It was fungating mass, he was bleeding, he was pouring pus from there. So the patient came to me, we investigated the patient, it was the only site of recurrence. And post chemotherapy, it has not increased, it has not done anything, there was no further meds. So we decided to give it a chance to the patient because he was already bleeding. I knew we won't take care of that thing, he'll die in a short course of time. We operated. So imagine a patient who has been given 3 to 6 months. He is now almost 1.5 years post surgery. He had taken radiation. Till now, no recurrence. He's doing fine. One patient came to us from Africa. So that gentleman, one side mandible was done over with in this country.
Okay.
Second side mandible was broken into 2 halves because of the disease. There was a big ulcer here, and it was kind of inoperable at that point of time. So chemotherapy was given, immunotherapy was given, it reduced. Still nobody was ready to touch because it was a massive reconstruction which was to be done because the whole mandible has to be reconstructed. So I always say we took the surgery, patient is doing fine, he'll be going for adjuvant treatment now. So we always say, when we basically see that patient, we always say, this man came without a face. He had no face when he came to us. There was nothing.
Yeah, so I've seen this case with you.
So this patient is going with a face now.
Correct.
Plus, his daughter came to me, see, any bone that is fractured, no? So when it rubs, when you do movement, it causes immense pain. And that pain can only be described by the person suffering from it.
Correct.
So imagine we have taken away the face, we have taken away the pain, we have taken away the disease. So disease came out to be 2.5 centimeter size, completely excised. Now that patient is disease free with a face, without pain. So one patient with you we have done. So that kid, David,
right,
also an amazing kid. He came to us with a massive tumor here on the back. It's called a desmoid tumor, a tumor of soft tissues.
Right.
So initially it was all stuck. It's too big. So we were not very sure that we'll be able to take it out completely or with margin. So chemotherapy was given. By God's grace, it responded to chemotherapy. And then we operated. It was almost this big tumor.
Correct.
And we were fortunate enough to take it out with clear margins. Because this place, I have already told, at that point of time, we told them that I don't know whether we will be able to take it out with margins or not. And I would say the kid and the doctor both are fortunate then that we could do it with margins. Now, see, I told you we sometimes deal with metastasis. So I'll just give an example. A Uzbeki lady came to us. She was a treated case of breast cancer, recurrence after 5-7 years, and there was one ulcer here, there was one ulcer here. Okay. So nobody was willing to touch again. That is the way it happens. But now as the things are progressing, we realize even with chemotherapy, these are the only 2 sites of the disease and we can take it out. It was easily operable. We operated, we put a thigh flap here, free flap done. And now it's almost 4-5 years, the lady is doing good, no recurrence, nothing. So it's just about, I feel in oncology, if you are concerned about the patient, if you're working for the patient, you will do good. You will do good for the patient also, and you will do good for yourself also.
Right. So when I gave it 2 examples, one a kid and one an adult. So if we talk about you, doctor, so are you treating the what age group of patient do you normally treat?
So I basically treat solid tumors. So I don't, so except for bone tumors, which I don't treat, which basically my orthopedician colleagues treat, and the neurosurgical tumors, the brain tumors, I don't treat. Rest, be it head and neck cancers, be it breast cancers, be it abdominal thoracic cancers, be it sarcomas, I deal with all because I'm a trained surgical oncologist, MCH in surgical oncology. And age groups, we deal with all age groups. So from kid to adult, we treat all age groups. The only thing is, the most difficult part is to treat kids. See, adults, you can relate to them, you can make them understand what they are going through. Kids, it becomes a sensitive issue. We all are parents. So somewhere you start seeing your kid there. And it becomes a sensitive thing, it becomes a painful thing. So for me, it will always be very, very sensitive issue, very, very painful thing to treat a child with cancer.
So I've been talking to somebody before. So it says somebody says the doctors are they don't have that emotions into them. But talking to you about the kids, you seem to be an emotional guy. But when you have when you're there in an operation theater, so whether the emotions do come into the picture or you become a surgeon. And
I'm a combination of a surgeon and a human being. Right. So I'm afraid at times. Yes, I'm afraid. Why I'm afraid? I'm not afraid for myself. See, I'm going to operate on somebody who has trusted me with his body. So I'm afraid for that person. So do I have at times you question yourself also. So we see eventually at the end of the day, whatever we say, we all are human beings and we have a tendency to question ourselves. We all question ourselves also.
Right.
And every surgeon is somewhere emotional. But then when we go to OT, we keep that outside because with a lot of emotions running, you will not be able to take decisions which are mandated to be taken. Right. Sometimes it will be inoperable, but if you are very, very attached to the patient, you will try to do more harm than cure. So to be rational inside the OT, I'm a surgeon, and that is the way we are trained that way. We have been trained for years and years to be that way.
Right.
So outside the OT, yes, things are different.
So, sir, as per the doctor's perception, a patient treats you like a god, right? But there's the Almighty upstairs, right? So, how do you see yourself when the patient who you're treating have everything on you? They treat you like a god, they worship you like a god, but there's a God always there who you also pray well before you going into an operation. So how do you take that as an expression to what the people come to you as?
So I always tell even my fellow doctors as well as the patients, and see if you ever see me talking somewhere, I always tell my patients also to take me as a professional, somebody who is trained to do something. Just like a plumber, just like a carpenter. I'm someone who has been trained enough to operate on people. So I am not God. I am not even God. I'm not somewhere near to God also. So it's just me. I'm just a human being who is doing his own job and I'm earning from it. That is it. For me, it's very, very clear. It's very, very clear picture. And for me, God is there. Right. See, if I would have been God, then I would be able to give same kind of outcome to every single patient I operate, which I am unable to. So every time you have to introspect. So I always call it pseudo-God syndrome. So it exists in medical community that somewhere we start feeling that yes, we are capable of giving results, we are capable of changing life. No, we are not. So it's his job. He's much above me. My job is to operate and give whatever best of knowledge and skills I have to the patient, because see, at the end of the day, we are into private sector. Patient is definitely paying me to get done something. Correct. And I must give him the value of money or more, whatever he is paying to my hospital for my services. And I always consider myself to be someone who is into a service industry with some skills which may be better than few, worse than few, and that is the way it is.
Also, we have seen recently that a person, a normal human being, working in office, suddenly found out that he's not feeling well. He goes and gets some tests done and he finds out that he has a cancer. So is it something to do with the lifestyle, or is it heredity, or what are the chances of a person getting a cancer if they're already in the family? Is it a genetic, it will pass on from generation to generation? And what are the precautions they could look into so that they can live a healthy life?
See, it's a lifestyle disease. There is no question about it. That's a lifestyle disease. So whatever we are eating, whatever we are drinking, whatever, see, it's these two.
Right.
So whatever is going inside is causing harm. So now, if you basically see the current scenario, we feel cool when we basically go for alcohol, tobacco in any form. So if you go to small cities, it is more of a chewing tobacco. If you come to cities like Gurgaon, Delhi, it is more of a smoking tobacco.
Okay.
So cigarettes is what tobacco only. So now the problem is when you basically use these things. So if we talk about tobacco, there are so many carcinogenic. So these have chemicals. So everything that you basically use is a chemical. When you burn it, it produces more chemicals when it reacts to the surrounding oxygen and the air.
Right.
So now tobacco is one part. Okay. So if you basically read about cancers, every single cancer in the body has tobacco as its one cause. Okay. It will always be at number one. Now, when we talk about alcohol, at one point of time for 60 ml is healthy. Now, all data is coming. Data is saying that zero amount of alcohol is healthy for your body. The another problem with alcohol is a solvent. So if you see industry uses alcohol as a solvent.
Right.
So now alcohol has a tendency. One, alcohol itself is harmful. So now whatever you are drinking, so when it gets converted into the body, it converts into acetaldehyde. So have you seen the body is being preserved? They are preserved in formaldehyde.
Right.
Acetaldehyde is sister concern of formaldehyde.
Correct.
So now alcohol gets converted into acetaldehyde. Whenever you keep it in your mouth, it is getting converted. In your intestine, it is getting converted.
Right.
Plus, at the same time, it is acting as a solvent. Any toxin inside your body, you have eaten food with toxins, alcohol helps that toxin to go inside the bloodstream.
Oh, okay.
So it will increase the effect of those toxins. See, food we cannot control. Whatever is coming to our plate, we have to eat it.
Right.
Air you cannot control. Delhi, Gurgaon you are living, you cannot control air. Air is going to be there.
It's there.
What we can control is how we are doing things, what we are taking in form of added substances. There are multiple other studies, things are going on regarding how other things are affecting. So one more thing is obesity. So if you see kids also, adults also, people are going obese. Now, what happens with obesity is there are multiple things that are happening in your body with obesity. The colonic emptying time is slowing down. So if your intestines slow down, what will happen is the toxins will have more time to get absorbed. One thing. At the same time, it is causing changes in your body in terms of hormonal disturbances. So now when you are basically having hormonal disturbances, hormone-related cancers will increase. So if we talk about women, there are a few cancers which are hormone-related. One is breast, one is ovary. So now these will automatically start increasing once your hormone levels are increased. Plus, we are exogenously taking hormones. So if you, whatever food you are eating, there are a lot of people are injecting hormones into even vegetables and all. So definitely this is causing this is one part. Plus, stress. See, we don't count stresses too much, but actually it is one of the biggest. See, it is taking away your sleep, it is taking away your health, it is taking away your immunity.
Right.
So see, most of the cancers, it's not that cancers were not formed 200 years ago in our body and now they have started forming. Cancers are forming every day in your body. There are cells which are cancers. Now what happens is the immunity will take it, kill it, done and over with. Your cancer cannot get established. See, there are circulating cells which will be there. Your immunity. Now, once your immunity is destroyed or it gets toned down, what happens is these cells get a chance to embed themselves somewhere. And if we talk about genetics, yes. See, eventually, I think two different people doing the same thing continuously, one will suffer from cancer, one will not.
Right.
One person smoking from age of 17 to age of 65, nothing happens. One person starts smoking, 5 years down the line, you have cancer.
True.
So there is some susceptibility. So now we are not reached to that level. We are trying to, but there is definitely susceptibility.
Okay.
So now if you have susceptibility to tobacco, so you also don't know, I also don't know. So we have no idea that we are susceptible to these products and we should not be using it. Once we start using them,
then you know.
Then only after 5 years you get to know, okay, you were susceptible.
Right.
Plus then there are genetic cancers. So if you have someone, say like breast cancer, ovarian cancer, there are few cancers which run in, colonic cancers, which run in families. So there are certain tests prescribed. So when you go to meet an oncologist, if you have a cancer in your family, and young cancer specifically, so if you have a cancer above 70, I won't consider it too much to be a hereditary one, but you have a cancer within the age of 40, 50, so the children and the first blood relative should go to doctor and consult. So they will tell you multitude of tests which needs to be done, at what certain age they need to be done. So now there are few cancers which are related to virus. So it's very peculiar. Okay. So there are two cancers, especially liver one, which we all know, hepatitis B, hepatitis C one. The most curable cancer in our body is cervical cancer and the oropharyngeal cancers, which are related to HPV. So there is a virus called human papilloma virus. Now it causes few cancers like penile cancer, vaginal cancer, vulval cancer, cervical cancer, and oropharyngeal cancer. And there is a vaccine for it. Imagine. And we are not getting our kids vaccinated for it.
So that was where I was coming for. That it's been advertised a lot these days that the kids should have the vaccine done. So what is the prescribed age to get the vaccine, and how important it is to be vaccinated, and why it has not been promoted so much? That it's a precaution. It's a precaution to help you from the future diseases.
So see, hepatitis B, hepatitis C vaccines were already included into immunization program. Now every kid, whoever is basically born in India, is going through that immunization program and they're getting it.
Right.
HPV vaccines still are not made mandatory. I think in due course of time it will be. So the vaccination starts at the age of 10.
Okay.
And the reason being, so it's preferred that you should get your child vaccinated before turning age 15, because the reason being, human papilloma is a sexually transmitted disease.
Okay.
So now, before the first exposure of sex,
right.
So this basically vaccine should be given. And now they have basically gone to an extent. Earlier it was 2 variant vaccine, then there was 4 quadrivalent, 4 variant. Now they are nonavalent vaccines.
Okay.
So 9 variants, out of which 7 are high risk, 2 are low risk. So now what the vaccine they are giving is preventing the warts also.
Okay.
So no, they are the low risk ones, they cause warts. So now they are including 2 low risk ones also. So your chances of developing warts also in later life are gone away.
Okay.
So I prefer that all parents should take it in their, basically keep it in their mind that once your kid is above 9, there are 2 doses which needs to be given, and you should get your kid immunized against human papilloma virus.
Right.
And now it is advertised. Now it is basically, people are doing awareness program. People like me are advocating it. Every patient who comes to us, we counsel them to get it done, because see, this is one virus which causes STD. This is one virus which is causing cancer, and not one side cancer. So it is oropharyngeal, penile, vulval, vaginal, cervical cancer, and these are potentially life-threatening cancers.
Right. So is this vaccination to get more awareness on the vaccinations? So is this the parents have to see oncologist?
No,
or a gynecologist, or a
pediatrician, gynecologist, oncologist, everybody is now prescribing this.
No prescribing it. So it's an OPD based, no
OPD based, no side effect, very, very minimum. See, we have all got through hepatitis B vaccine,
right?
Kind of same vaccine, not much of a difference.
Right. So when we talk about cancers and what treatments being offered, how do we diagnose a cancer? What are the basic tests where anybody can get it done? Because we've also seen that people do not go for any blood test or any scans till the time they don't feel sick. Now, is there a preventive care program, some tests which are there already, a person should have once a year at least to get it done, because of these lifestyle issues which we are having, till the time we actually we get something in our body, we're too late. We've seen sometimes we're already too late.
So first I'll address, basically what you have asked about is a screening program. Then at the same time, the question is always like when to get it done.
Right.
So when to get yourself checked. So first I will deal with the screening program. When you are not having any symptom, there are any tests to be done. Yes. So one thing is you should get your annual checkups. No, we all have insurances. We are getting annual checkups for free, or organizations are getting in that. So usually when you go to a doctor, you are examined, you are advised few blood tests, and you are advised some ultrasounds, chest X-rays. So if there is any suspicion for malignancy, we can get it very easily. There are a few screening programs. Now, screening program is a program where you get the investigation done before you have any sign symptoms of a malignancy. So the most commonly running program is for breast cancers. So it is an easily diagnosable disease, and we have mammography and ultrasound. So under the age of 40, we prefer an ultrasound, and above the age of 40, we prefer a mammography. So usually prescribed thing is to go for a ultra sonography plus mammography above the age of 40 every single year. We basically prefer it that way, and it's a very, very cost-effective thing also to diagnose the breast cancer. Second is for colon cancers. So after the age of 50, you can get basically a colonoscopy done. Cervical cancers, pap smear, and human papillomavirus testing is there above the age of 30. So it starts at 21, but above the age of 30, you get HPV plus combined testing done. Right. For prostate cancer, it is PSA. Now for smokers who are long-term smokers, low dose CT as a screening thing is being used. So now next thing comes is, so these are for people who are not having any symptoms. So now how do you know? So for me, I know. I'm a doctor. You are basically working with me. You understand. But for people who are listening to us, they have no idea.
Correct.
So I always say one thing. So you should basically take it in your mind that any change from your routine. So now we all are creatures of routine. Human beings are creature of routine. From morning to evening, we have a fixed day. We will wake up at this time, we will do brush, we will basically go to washroom, we will take a bath, go to hospital or wherever you work, come back, you eat. So you know what you do. And you are master of that. Now if there is any change, slight change. So your mouth was opening, now suddenly stopped opening.
Mm-hmm.
You have bad breath without any cause. Everything is normal, your teeth are not bad. Your tongue was protruding, now it is not protruding. Your voice has a subtle change. Your gut habits are changed. You used to go to washroom once a day. Now it's like suddenly 3 times a day. Or you never had constipation, there is sudden onset of constipation. For women, so you have a lump somewhere, you have change in shape or size of the breast, there is any change in the color of the skin, anything. You started losing weight, you cannot sleep properly. So any change that is happening in your body. And if you observe any change from your routine, please go to a doctor. At least get checked. I'm not saying it is cancer. So what if it is?
Right.
You'll get the answer.
And how important is the role of PET-CT in terms of cancer detection?
So see, PET is an amazing device for us, for the cancer surgeons, and for the basically oncologists. Now we don't say routine people should go for PET-CT. The reason being, so if there is PET, how does PET works? So PET works in a way that they give a compound for you to take, and that compound is usually 5 mg. So it's kind of glucose, a container of glucose. Uske upar we have tagged something. Now cancer is basically thing which basically takes up glucose, because rapidly growing, anything that is rapidly growing needs glucose. So in the PET-CT they see it bright red and orange.
Right.
No, but this can happen in other diseases also. It can happen in basically inflamed lymph node. It can happen in any inflammation, if there is any pus, if there is history of injury, if you have been recently operated. So for a routine person who has no symptoms, there is no manifestation, getting PET is going to land him in problem more than the advantage. The reason being, if somehow they see one, I know one gentleman, he's a very good friend of mine, he got a PET-CT done, and PET-CT showed multiple lymph nodes which were FDG evident. Okay, now it has been 10 years. He is living in fear, Every single year he gets his PET repeated. So no, it was futile. There was no point. It could have been simple. Multiple times you have upper respiratory infection, you can have lymph nodes, you show PET. So PET is to be used very judiciously, and specifically it has to be used in consultation with your oncologist. Now, why do we get PET CT done so commonly in India? So it's a very, very common question. People think it's to our advantage. We are getting something out of it. No, we are not. So now why? The reason being, if you get the PET done outside of this country, it is very, very costly. Very, very costly.
Right.
So now because it is very, very costly, plus they don't get the dates. Now, if you're getting a date for PET for 6 months afterwards, why would you get it done? You will try to get some other investigation done.
Correct.
Now in India, if I have to get the chest CT, neck CT, abdominal CT, every CT, the cost of those total number of CTs will be twice as much as a PET CT.
Right.
Now PET will give me more information in half the cost. Plus you can get the PET CT done tomorrow. See, we have a different scenario altogether in India. We have a different set of conditions, we have a different set of problems, but we have different set of advantages also. That's why when you go to an oncologist, they prefer to get PET CT done to have a baseline. See, now I am getting treated today. So if I have a baseline PET, next time whenever I am going to get a PET CT done, it will be compared to this baseline. So we will know if there is any change or not. So that's the advantage.
Now, but when a doctor prescribes you to do a PET CT, there's something goes on in the patient's mind that he has a cancer. It could be end stage, it could be pre-stage. So if I give you my own example, 2 years back I was not well. So losing a lot of weight, appetite was gone. So could not be diagnosed anything much. So one of the doctors advised me to do a PET CT. Being into healthcare profession from 21 years, the first thing I came back, I don't want to get a PET CT done. Right? This is not for me. Then I called one of my doctors. He said there's no harm in getting a diagnosis. At least you'll be of ease of mind, at least if nothing comes out, it's ease of mind. If something comes out, we treat it at the right stage. So that makes me to get into. Now, there are a lot of countries where we see the PET CT is not available. Now, a patient traveling all the way to India just to get a PET CT done and a diagnosis does not make sense. So what is an alternate which they can think that, can give them a sense of what lines they have to go through?
So what happens is, so PET CT is a combination of two words. One is PET, one is CD.
Right.
Okay. So it's basically, so CT is good enough. So you see, if you want to diagnose something, the CT is the part.
Correct.
PET gives me an advantage in terms of, because it basically doesn't uptake. So it's like wherever that will show, I am very sure that it might be cancer. So now it can be replaced. Countries, there are countries, not even countries where PET CT is there, but it's very costly, very difficult to get done.
Right.
So guidelines are clearly stated. PET CT is not mandatory. It's an alternative investigation we are using because it's available to us. Otherwise, a chest CT and an abdominal CT is good enough. Okay. And plus, every cancer has a set of metastasis. There is a certain way that it will spread. So it has to go to this place, then its place. So you know the route. So accordingly, you get the CTs done. So if I have an oral cavity cancer that is coming to me, a chest CT is good enough. I know it will not go, it will not just skip the whole thoracic, it will not go into the abdomen. So there is a certain pattern of, cancers also are not totally devoid of patterns. There is a certain pattern and the oncologists know that pattern. So a CT is good enough. For abdominal cancers, I'll get a chest CT done. So see if they are spread to, because the most common part from here to here and here to here. So that is the way it is.
So in terms of, because you have a community of doctors and oncosurgeons, but something very important is again, if you talk about a layman, a patient's point of view, if he's been diagnosed with any kind of cancer, he's confused to go to which doctor. Whether he go to a surgeon, he go to a medical oncologist, or he goes to for the radiation oncologist. Radiation comes as a second stage first. So between a medical and the surgical. So it's been believed that there's a tough of war between both, that who's going to treat the patients medically or surgically. A surgeon is believed to have wanted patient to get a surgically done, remove the complete thing, and the medical oncologist to take it further. So, what's your perspective as a doctor?
So I don't think, these all are created into the minds of people. I don't know how these things get created. So we usually follow European guidelines or NCCN guidelines. So there is a certain set of investigation, certain set of treatment that has to be done. Who will do first, who will do second, that is also described. Very rarely it comes to a place where there is a decision dilemma who should go first, and for that there is tumor board. So we have created a tumor board where there is a medical oncologist, radiation oncologist, nuclear medicine guy, pathologist, radiologist. We all sit together. We deliberate over it, and then the decision has to be made by tumor board. The board will decide who it will go to first. So see, oncology, there is never a confusion. So the confusion is always in the mind of people. So if you have a dedicated, thorough structure made in your hospital, these kind of things will never happen. Then we talk to the patient also. We tell them, this is the way it is. There are two decision making. There are two decisions which can basically be looked at by you, and then it has a very, very transparent process. They should understand what is going through. So we never had a problem. I never had a problem in my previous hospital. Also, I never had a problem in this. Wherever there is something which is in between, I'll sit with my medical oncologist friend. I'll discuss with him, see what needs to be done.
So the team of doctors and the board, they sit together and decide what's good for the patient.
Yes.
Now, one thing we didn't ask you, doctor, is after finishing your MBBS, how did you get into a surgical side plus an surgery side? What fascinated you, or is there something you already had it in your mind before you started your medical journey?
So I wanted to be a doctor. I wanted to be a surgeon. That was for sure.
Okay.
So see, post MBBS, you give exam. You go to general surgery, finish your general surgery, and then you decide on future course. So once you finish your general surgery, you have multiple options. So I initially went into senior residency into cardiothoracic vascular surgery. Then I had my senior residency into general surgery. Over the period of time, you start developing certain skills, certain set of skills, and your basically view towards certain branches. So I decided to pursue MCH. It was always there in my mind. See, in India, you always have it in your mind. If there is a degree remaining, we go and do it.
Okay.
So I had that in my mind that I have to do MCH. So when I went for MCH, people around me, they were very sure that what branch I should take. So I discussed it with my colleagues, everybody, because you need to take guidance also. So they were, throughout, it was a unanimous decision that you had a decent surgical hand, and so you should go to surgical oncology. So we went to counseling. I got surgical oncology. Initially, it was difficult because see, when you basically see the outcome, when people are dying, you don't like it. First 4 months were like, why I chose this branch.
Right.
Then that came to me. If not me, then who? So you realize, okay, fine, whatever it is, let me do it. Let me take away pain of the people. If I can do better, if I can do good to people, why not? Why not? Why leave it to somebody else? So then, since then, it is a journey. You come to a branch, you choose a branch, you learn, you keep on learning. I am still learning.
If you have any queries related to oncology, related to any question related to the medical treatment options, you can always DM us. And for more information, we will always get back to you.
So thank you, Vishal, for this podcast. So we have delivered in this short duration as much as information we could to basically make you aware regarding cancer as a disease and the treatment option available. So if you have any queries, if you feel you need to consult us, please do DM in the comment section. Thank you.